Peter también fue pediatra consultor en el Royal Free Hospital de Londres, especializado en el desafío de las condiciones a largo plazo para los niños. Ha sido el líder clínico nacional para SAFE, que es un programa financiado por la Fundación Royal College of Pediatrics and Child Health, que tiene como objetivo mejorar la conciencia de la situación en los equipos clínicos. En Irlanda es profesor internacional principal en el Royal College of Physicians en Dublin, donde codirige el programa de liderazgo y calidad para desarrollar líderes clínicos en la mejora de la calidad. Es cofundador y presidente de la Comunidad Internacional de Seguridad y Calidad del Paciente Pediátrico. Doctor Peter Lachman, muy agradecido por su presencia y vamos a escuchar su cátedra.
Thanks very much for inviting me to speak. Just let me know if the internet connection goes off. It seems to be something going on here, and I will then just move to another position in the house. This is one of the problems of having to work when everyone's using the internet as the main place. Usually in September, I come to visit you in Buenos Aires. I've been doing that for the last 3 or 4 years. So this year it's a little different. I had planned to come around in October, but it doesn't seem like that's going to happen because of COVID. Over the next 30 minutes or so, what I'll be doing is giving you some thoughts on patient safety and how we can make things safer for the future. I called the talk Beyond Patient Safety because I think that it is quite easy for us to get stuck in the concept of patient safety as it was rather than as it should be. So as you heard, I work for ISQA, the International Society for Quality in Healthcare. We have quite a good presence in Latin America across the different countries and in Argentina, and we're very pleased to be with you here today. The vision that we have is on the slide, and it's about transformation and of health rather than of health care. As you can see, we talk about transform the health of people. And right now, I think that that is a crucial part of what we have to do in this age of COVID, is talk about the health of people and then the quality of the healthcare system. There's a difference between health and healthcare. Healthcare usually refers to disease management in hospitals, whereas health refers to the health in the community. And right now, in the COVID era, we need to look at the health of people, and in particular, the health of people who are not getting the care they normally got, or perhaps may need to get care in a different way. So how would we look at patient safety within this kind of vision? Now, ISQA develops or gives its programs through 3 key principles. One is what I'm doing today, is sharing some knowledge. Secondly is to develop networks, and that's why we work quite heavily in Latin America with the different organizations, and we have regular webinars called COPLAC, and something that you can do. We also about to launch in Latin America a fellowship program in Spanish with teachers and input from all the different countries in Latin America. It's first going to be in Spanish, and then hopefully in the new year we'll have one in Portuguese to cover Brazil. We have this program is going to be available to people in the region, and hopefully this will help spread the knowledge And then finally, we give people a voice, and that voice is to share information and to learn from each other, because that is how we are going to make a difference in patient safety. It's really from the learning from each other. So let's just stand back for a second and say, what is the reality of the patient safety movement? So a story from myself is I'm a pediatrician, and I always start with a different story, but on this one, I will give you the origins of my interest in patient safety, which happened many years ago before we were even talking about patient safety. The first time I ever heard about harm to patients was when I read a book by Ivan Illich called The Medical Nemesis, which he wrote in the 1970s when I was a medical student. It was a book that we were told that we shouldn't read, but that meant we all read it. And in it, he basically said that 10% of people who go into healthcare facilities are harmed. So what does that mean? If 10% of people are harmed? Well, is there a problem with the sound? Sorry, no? Okay, 10% of people are harmed, and that was without any figures. Now, if you look at healthcare around the world, people say 10 to 15% of people are harmed. So that was the reality in the 1970s. And what has changed now? Well, we still harm 10 to 15% of patients, and that is in all figures worldwide. So there have been successes, but there is much to achieve. Is it because we are changing the definitions of patient safety, of what is safe, what is harm? Or is it that healthcare has become more complex? Or is it that we are doing different things? So for example, we have an older population, and as a pediatrician, we also had a younger population. So in pediatrics, neonatology has a whole area of harm that didn't exist before. And in care of the elderly, there's a whole series of harm that didn't exist before because people didn't live that long. So there are many very different reasons for what we have. So let's look at the evidence that we write now. These are 3 documents that came out in 2018. The first was the one on the right, is the one from the OECD and World Bank and World Health Organization. That's the positive one. The next 2, the global crossing the global quality chasm, came from the national academies, and the one from the center comes from the Lancet Commission, which some of you may have been involved in. Now, these 3 documents were published in 2018. Funnily enough, not many people talk about them now. I'm not surprised, because what they said is that 8 million deaths occur from unsafe or poor care worldwide. Now, that sounds like a large number, but actually it's an underestimate of the number of people who die in lower middle income countries. And it hasn't included those who die in upper middle income countries. In 2020, at the turn of the century, 1998, 99, crossing the global chasm was crossing the quality chasm was published by the National Academy, then called the IOM, Institute of Medicine, in which they estimated that 100,000 Americans died every year from harm. So what this is showing is that on a worldwide situation, this still is the case. So we still have a major problem. So let's look at what their recommendations were. And these are the recommendations. I've summated them from all the different reports, and they basically give you the key ones. And the ones that you may in Argentina say, which are the ones that apply to us? Do we have universal health care? You do. Is there good accountability in the system? Is there systems thinking? I mean, are we thinking of how the system works? Do we have good quality measurement? I mean, do we know how we are working? How do we adapt to new technological advances and digital health? What are our priorities in the system? And how can we address issues like corruption? Corruption varies in different countries, and everyone has a degree of it somewhere. And what is our culture? So these are the recommendations that they came out from that report. And the problem with these reports is when they came out, they were put high up on the agenda. And since then, we have had many different things happen, and these reports seem to have been forgotten and not been taken into account. Just to look at the United States, where often people look there to see what is it like in the United States. Well, here's 3 different reports. One is from David Bates and Hardeep Singh, which really talks about 2 decades after To Err is Human and Crossing the Global Quality Chasm. Are we safe? The other is from Tejal Gandhi, who worked at IHI when this was written with Lucian Leap Foundation, saying what has happened. And the third is a book by Kathleen Sutcliffe and Robert Weirs. Kathleen worked on a lot of the reliability theories and saying, despite all, we're still not safe. So this is in 20 years on after the seminal event on To Err is Human and Crossing the Quality Chasm. And I take this quote from David Bates's paper, which he says that we have highly effective interventions, for example, on infection control and medication safety. Those are the 2 highest harms that happen to people. But the inconsistent implementation is the problem. So the problem is one of implementation. So we know what to do, but we don't do it for very many different reasons. If you have to think about it, why is it that hospital-acquired infections is still a problem? We know that before COVID, hand hygiene in hospitals was a major issue, particularly amongst medical staff, as opposed to nursing staff. Why is that? One of the positive outcomes of the COVID pandemic is that people are now paying attention to hand hygiene, if you have to think about it. Even the public are doing that. When you go out here, I'm in Dublin at the moment, if I go to buy a cup of coffee, there will be hand hygiene at the point where I'm buying the cup of coffee. I also have to wear a mask to decrease infection. So COVID is going to have a major effect on this, but we know what to do in many cases, but we're just not doing it. So implementation is a major issue. The key recommendations from these papers are these, a little more simple than the ones from the 3 papers the year before. One is that we have to educate people for safety. That's educating the current workforce, the doctors, the nurses, the other healthcare professionals, but also educating the future workforce. Do we educate for safety, or do we educate for providing healthcare? Patient safety is a major issue, and we're not educating for it at all. How do we integrate care? Is this a major issue, or are we integrating in a way that doesn't benefit people? So, for example, the primary, secondary care, tertiary care, quaternary care divide means that a patient who now is more complex has to navigate different systems in order to get good quality care. Are we doing it well? The COVID pandemic brought out the next one. Are we dealing with the psychological and physical safety of healthcare workers? We're not doing this pretty well. And I think that we need to work out something that is far more beneficial to workers to ensure that they feel safe. And in COVID, this was a major crisis worldwide, something that we can learn from very easily right now. Then there is the next recommendation is that we need partners in the coming to the solution. So it's not something that we do to people, but we do something with people. So patients as partners in co-production. And then finally, this idea that we need to be transparent. And transparency is something that we're not very good at in healthcare. So when I was last in Buenos Aires 2 years ago, I think we had a talk at one of the conferences on the importance of open disclosure, and it created a lot of debate because that's about transparency, about being open, because there are medico-legal issues, there's societal issues. So it's very easy for me to make these kind of recommendations from what they made in those papers, but to implement them is a different matter. So how do we go forward? That's the question that we have to look now. And just to keep you even up to date, this is right from last week at the Institute of Healthcare Improvement and a number of organizations in the United States. They published, because it was Patient Safety Week day last week, and Patient Safety Week was at WHO, they introduced this framework, which is very interesting to look at. It's called Safer Together. You can see, and they have implementation resource guides, and they have an assessment tool to see whether you're safe. So it's quite useful, but you will have to translate it because it's, of course, American and doesn't really apply everywhere. But look at what their recommendations are. They have actually 17 recommendations under these 4 categories, very similar to what was there before. That you have to have the culture, the leadership and governance. There's the accountability, developing a safety culture. You have to have patient and family engagement. You see that was from before. Workforce safety, that's there as well. And then having the foundation of a learning system. So the recommendations are the same. And if I look at recommendations from papers in 2008 to now, the only one that really has been jumped up are the patient and family engagements or co-production, and workforce safety is now coming up forward. But really, the solutions are the same in all these new papers. So the next thing we have to ask ourselves is, how do we move from patient safety to safety? And when I talk about safety, it's about safety of all the people involved within the process of healthcare and delivering health. So that is the family, the patient, and the healthcare workers, the providers of care, and the healthcare managers who manage the system. How can we make sure we are within a safe system in order to deliver care? So that's a big question for me. And I think that possibly we need to start changing the debate and start thinking rather prospectively rather than retrospectively. Patient safety is not something that we can just take lightly and say patient safety. I think we have to talk about what is our business in healthcare and in delivering health. And it's not only to manage disease and keep people healthy, but also to keep everyone safe. And we have to think about the issue of implementation and how we have designed healthcare. That's the hospital systems and the clinics and the way people traverse it. Have we designed it for safety? Or is it something that we have to really rethink on the design? If we had to design it now, would we do something? And for me, as someone who's been trained in improvement and implementation science, how can we use these new sciences in order to improve our healthcare? So in essence, we have to think differently. We have a call today with Eugene Litvak, who was at Esquire, and he said something. He said, if you keep doing the same thing over and over, thinking you're going to get another better result, it's just a sign of insanity, of just be crazy, because it's not going to happen. We have to think differently. So I've been working with Paul Bertelden and with Chris van Hecht from Belgium, and to look how we could move beyond this patient safety. And I'm going to present a framework that we've just put out for consultation in F1000 research, so anyone can comment on it if they wish to. And this is a framework that we've been working on over the last 6 months to look at a new way we can think about patient safety and quality of care in the post-COVID phase. So I'm going to take you through this because I think that this might help us move to beyond patient safety. So how we're looking at it in the paper, we'll talk about quality one is where we started when we started the standards and accreditation, is seeing that we set standards and set to see people if we met those standards. Quality 2.0 is where we've been for the last 10 to 15 years. These build on each other and they're complementary, is the quality improvement movement that we've had, in which we had tried to improve what we're doing already to make it better for the population. And now we think that we have to go to what Paul calls Policy 3.0, which is the co-production of health with the people who receive health and the people who provide health. Can we co-produce quality care together and co-produce safety? Fundamental to this is re-looking at the domains of quality and safety. So in 2000, or in Crossing the Quality Chasm, the Institute of Medicine came out with 6 domains of quality. These you all know about it. There's the quality of safety, to keep people safe. Effectiveness is, are we doing the right thing, giving them the right treatments? We know we're not doing that reliably, that we do know. Efficiency is, do we have waste in the system? And we know we're not doing that very well. Timely care, we know that we keep people waiting, so we don't do that well. Equity is a big issue now. In COVID, I don't know what it's like in Argentina, but the social determinants of health really revealed themselves in the COVID pandemic. And what happened was that people from lower socioeconomic status or Black and ethnic minority groups, they had far worse outcomes than those who were from upper income statuses. So we knew that as well, and person-centered care. So these are the domains of quality. So what we've done is we've said we need to really just rethink this slightly. So we take away person-centered care and we surround all the domains of quality with the idea of the person or kin. I'm not sure what it says in Spanish, but kin in English would refer to the family, the wider community. So person or kin-centered care, we think surrounds all the forms of patient-centered care. And I think that if one thinks about it, is that you cannot be safe if you're not person-centered. You cannot be equitable if you're not person-centered. And so it applies to all the different domains of quality and safety. And then we add the new domain, which is eco-friendly. So that is the fact that our hospitals are not environmentally friendly, our systems are not. We have a lot of environmental issues in the way we run our organizations and our healthcare systems. So that should be a new domain. But core to the whole center is what's in the middle. And this is the concepts of kindness and compassion, respect, co-production and partnership, and holistic care. So let me dwell on this, which I call the heart of the quality system. What I find in Chris van Hecht from Belgium has just published a book called Mango Moments, which refers to small acts of kindness that happen every day in our health system, that add something of value and make people feel safer, both psychologically as well as physically. The idea of compassion and respect for each other, respect across the divide between patients and doctors, from primary to secondary care, within hospitals, this idea of respect. The concept of co-producing health in partnership with people as a core value, and finally, providing holistic care, not only care of the physical, but care of the mental well-being. So where I think this is important is that if one reflects what happened in the COVID pandemic, and I can only comment on what happened, say, in the United Kingdom or in Ireland where I am, is that even now it's happening that mothers are giving birth without the father present because of some rule on COVID, that their father cannot attend the antenatal meetings or cannot attend the ultrasound. That's in birth. And at the other end of the spectrum, people dying alone without their family, no funerals allowed, the lack of respect and lack of compassion in order to fight the virus. So what happened in the COVID pandemic is we became super safe in trying to prevent infections, but lost our compassion. And that had a big toll on people who were compassionate and wanted to be, but couldn't because of infection control. So the balance was not there. So we think that if we had a model like this, when we were talking about quality and safety, we would have the core values always with us to ensure that we're safe. And we would surround this with this concept of transparency, so that we would be transparent in what we're doing and we would support each other. So we were working on this before COVID. We started our ideas before COVID in trying to work out how can we bring kindness, compassion, and respect back into healthcare. And then COVID came, and it proved to me, at least, that these are the values that we need to do to protect both the physical and psychological safety of not only the patients, but of the healthcare workers as well. And I think if I talk to most people, that's why they go into healthcare, because this idea of kindness and compassion. In the Mango Moments book, and I really recommend that you have a look at it. We can send out the link to it. We get stories from people about compassion and about kindness being the foundation of safety. And so this is where I'm talking about going beyond the what to do. We know what to do. We've got to return to the why, and we know how to do it, but the why will get us there. So this is our new domain. We're really looking for comments on this, and there are references down below which you'll be able to go and look. And it's in a journal that allows comments. So you can write the comments there online and we will be able to respond to them. So as I come towards the last part of this talk, just to finish off the other key messages, I am talking about culture, I'm talking about leadership, and I'm talking about learning. So as we move forward, the culture that I'm talking about of compassion and kindness, equality and safety is about the culture that we want to produce in all our organizations, which means we have to continually learn, but that requires leadership. And that is where, if we are going to make a real difference in patient safety and in quality of care, we're going to have leaders who prepare to do this. And that means that we have to move from beyond this focus on the rational all the time to dealing with the emotional, the inner being, the why people are in healthcare, the why they want to make a difference. And if you work on that as well as the rational, you'll get results. Too often we say to people, you must do it this way, but we're not appealing to the other part of the being of why we're in healthcare. And caring for the physical and psychological safety of people is essential for us to ensure that we will have safe care going forward. It will help us define what care should be and how we should be safe for the future generations of doctors, nurses, and of the population. I think that we also have to address in this time, we have to address this issue of equity in the way we deliver care, for whom care is provided, how we do it, whether it is culturally sensitive, and whether it is just. And that means that we are always open and we are supportive of the people providing care. And my last point of learning for today is a little more complicated. And what I'm going to just show you is that we need to refer to some basics. And that is using a systems approach in order to understand how we design our healthcare system to get safe outcomes. So over here, you see a model. There are many models. I particularly like this model from Pascal Carrion and her group, which is a systems engineering initiative in patient safety called SEAPS. And they have, this is their second version. They just brought out the third version. And it really shows you a way in which we can deliver safe care. And when I was introduced, people were speaking about the safe system that we're doing with clinical teams. And what we do there is ask clinical teams to really analyze themselves using this system on a daily basis, looking at how is their work system organized? What is the internal environment like for safety? What are the tasks that they have to do, and are people able to do the tasks? What tools and technology are required? And right in the center, this thing about the people. And that goes back to the model I was giving you. How are the people feeling today? Do they feel safe psychologically and physically safe? What's the kindness, the compassion, respect like? How is the team working? And really studying this on a daily basis, every day, once or twice a day, assessing how the work system is working, and then moving over to how they actually do their work, which is the processes, how they work with the people called patients, how they work together, interact, and how do they get their work done? Do they do that reliably in order to get their outcomes? And of course, outcomes can be desirable and undesirable. And what you want to do is limit the undesirable, increase the desirable, and they could be desirable for patients, for professionals, and for the organization. So you really want to work on that and have a feedback loop so that you continually learning. As you can see, the arrows come back up to the workplace. So what happens on the outcome is a continual learning environment. Now, I believe if we took this kind of approach and taught this to every clinical team on how to constantly analyze themselves and look at how they're working together and concentrating on the people at the center of the work system, the patients and the healthcare providers. If we concentrate on that, we'll make a real difference. So This is one model that one could use. There are other models. And I like to not think about safety 1, safety 2, safety 3. I'd rather think about how can we make things safe for people by giving them practical ways of doing this. And we've worked very well with clinical teams in doing this. So I'm going to end now. I just want to point out for those who are interested, the WHO has declared 2020 to 2030 the decade of patient safety, and they're currently out in consultation for their document or action plan. So I really recommend that all of you who have an interest in patient safety go to the WHO website and comment on this document. They're going towards zero patient harm. Of course, that's an aspiration because zero is like a mirage. We'll never reach there, but we must always aspire to go to that level. So I hope I've been helpful to you. Patient safety is a public health issue right now. And I think that if we need to do that, to deal with it, we have to think of how we manage public health challenges, as we are doing right now with COVID, in order to reach that position where we are managing safety in a different way. Because as Mahatma Gandhi said, you must be the change if you wish what you wish to see in the world, he said, but for us in patient safety. Thank you very much. I welcome you to Florence next year, should you wish to come to a conference in the hopefully post-COVID age. Thanks a lot. If you want to contact me, this is my contact level. Over to you, Ricardo.
Muchas gracias, Peter. No sé, Mariana, si ya estás en el canal de inglés para traducirle al Dr. Lachman.
Yes, I can hear. Yes.
Ok. Antes de trasladar algunas preguntas, voy a hacer comentarios porque lo han preguntado por chat.
Ricardo, no lo escuchamos.
La videoconferencia esta queda grabada en el canal del Instituto ITAES, tanto en idioma original como en español. Y tengo varias preguntas algunas van a ser muy filosóficas, no sé si van a ser simples de ser respondidas, pero bueno, sé que Peter de alguna forma va a lograrlo. Pero lo más simple, Sebastián Ávila pregunta si la ISPA tendrá un programa en español para Sudamérica.
The answer is yes. So we have, if I don't know if Ezequiel Garcia Elorio is online, but we run one across the whole of the continent in Spanish every 6 weeks. We will have a webinar. If you contact me, I can put you in contact with that. And we have we're going to launch a Spanish language program for education as well. We also will have our conference in 2020. In 2025, we'll be in Sao Paulo. So we'll be in Sao Paulo. So we'll be back in Latin America for the 2020 conference.
Yo espero, Peter, que nos podamos ver en Florencia el año que viene. El gobierno lo permita. San Pablo está muy lejos. Bueno, perdón, Mariana, le pido a Peter que entre la pregunta y la respuesta haga un pequeño intervalo de segundos para que tengas tiempo de switchar de canal.
Okay. Okay.
La pregunta, acá vienen las difíciles. ¿Por qué es siempre tan difícil delegar y crear líderes que satisfagan?
Yeah, so I think that I will say it's because we start too late. Okay, so I'm running a program in Ireland, which is an experiment in which I train young doctors to be leaders in quality and safety. So I'm just going to talk about doctors. I can do this with nurses as well, or with any healthcare professional. Is that in what we teach them in the medical school or the nursing college is more about the subject matter knowledge. We call that the hard skills. And the soft skills, which is the leadership, we don't teach very well. I actually think the leadership is the hard skill on how to lead for quality. And we have failed in our training. So I have, this year, I'm going to have 11 young doctors about to become consultants or attendings in the hospital. And they are going to be trained to lead, so that we're developing the leaders for the future. So it's not too difficult, we just haven't done it in the way we should.
Ok. Está más difícil todavía. Dice Norberto Larroca, mejor dicho, el doctor Di Santo dice que Norberto Larroca insistía en que el hombre sea el centro del sistema allá por el año 2000. ¿Cuál sería el motivo por lo cual esto todavía no funciona?
So, yeah, okay. So, you know, whenever I think about our current construct, I think that we need to look at the history of medicine and healthcare and where it evolved from. And when I was studying and doing my doctorate, I discovered Michel Foucault, a French philosopher, who spoke on the birth of the clinic. That was the book I read, Complex, in which she described how modern medicine came to be disease-focused, and the creation of what he called the clinic, which is our hospital system, which happened in the 1780s in France and then later on. And that's the model which we have to change, which is now 200 years of the model of healthcare. As we became more scientific, we became less person-centered, less focused on the patient. So what we are talking about is changing 200 years of culture. That doesn't happen automatically. But what has happened in the last 20 years, and why I think we're at a cutting point right now, is we have more information and spread of information, so people know what they should receive. However, the COVID crisis has proved how fragile this is of person-centered care and of patient safety, because we lost a lot of that in the last 6 months. And so we now need to redouble our efforts, but we have learned a lot. So I should be pessimistic, but I'm not. I think that we at a point where if we come together, we can make a real difference.
Pero preguntan si en otros lugares del mundo, incluido Estados Unidos, si está el tema de la seguridad del paciente incluida en los procesos formativos médicos y de enfermería.
So, yeah, okay. Yeah, so it's very variable. I would say, in general, the answer is no. So whenever I meet young doctors or nurses, I will ask them if they'd been trained in the theories of human factors, and the answer is no. So, for example, patient safety for me, for a medical student, I'll use, because as a doctor, I'll speak about medical students or nursing students the same. So we're in the morning when you have a ward round in a hospital and the senior doctor is teaching about the pathology of the disease. Let's say a 70-year-old or 80-year-old who's in hospital with pneumonia and has had diabetes. Okay, let's say that's the clinical situation. They will talk about the anatomy, the pathology, the pathophysiology, the pharmacology, the drugs to be given, but they don't talk about the human factors part, the risks, the risk assessment for harm, how to mitigate against the harm. They don't talk necessarily about safety issues per se. They talk more about it from a medical issue. So I think that the problem is that we have the teachers aren't trained in patient safety. So it's difficult for them to teach it. We are publishing, just to help that, I'm just bringing out a book to be in English in the first instance called the Oxford Handbook of Patient Safety, aimed at young doctors and nurses and medical students to teach them the theories in a way that can apply in their day-to-day work. But worldwide, it's limited, the amount of patient safety taught in medical schools. There are some very good programs, but they are few and far between. So if you don't have it in Argentina, you're not far behind the rest of the world.
Sí, creo acá la persona que hizo la pregunta no está identificada con un número, así que no puedo saber quién es. Ante la respuesta a esta, Peter pregunta o dice si el cambio no debería venir por este lado, y yo lo enlazaría con otro comentario que hicieron en el chat, si no debería ser de una vez por todas necesario introducir en las carreras profesionales de salud temas con mucho mayor profundidad, temas como antropología, bioética, aspectos relacionados con empatía hacia las personas, etcétera, 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 que serían fundamentales para que de una vez por todas se produzca este cambio de poner a la persona en el centro.
So the answer is yes, but the problem is one, what I'd say, of power and tradition. So if you consider again, let's just look at medical schools, because I think that that's where the change has to happen first. The power of the clinical disciplines and of say that there's just no time to add the soft skills. There just isn't time in the time. People have to learn things. So there is an issue of power relationships. People don't like giving up power. I also think that it's no use just having a course on patient safety. It has to be a thread throughout all the learning. I also think that we need to look very seriously at how we integrate young doctors when they come out of medical school into the workforce in their first 2 or 3 years of working. And this is where their mental well-being, their psychological safety, and their physical safety is often forgotten. Doctors who finish the place to really get them on patient safety is in their first years when they come out of medical school, because they're enthusiastic and they do have compassion usually. But in the first year, we often lose that in the way we organize our programs for them. And I know that when I work with young doctors here, that is what they report to me. So I think that we really need to stand back, as you say. We need to stand back and say, how can we go back? And that's why we have developed this model with compassion, respect, and kindness at the core, because we need to remind ourselves of the importance of these values, of why we have gone into healthcare in the first place, and we've got to find ways to reestablish them going forward. So I agree with you. It's a big challenge, but it is not impossible. We are at a new place, and now we have to go to this level of saying, can we redefine our healthcare system in a way that it is always compassionate and kind, as well as safe, while providing all the other elements of care that's required.
Bueno, creo que por razones de tiempo vamos a ir finalizando. De nuevo les recuerdo todo lo visto en esta conferencia va a quedar en el canal de videos del ITAES. Y lo que me están pidiendo, Peter, si también podemos tener los enlaces a alguna de las bibliografías que mencionaste.
Yes, what I can do is, if you just wait 1 second, I'll give you the link right here. Just give me 1 second. Oh, I've got to escape here. What I can do is I can send it to you. I've got it right here for you in 1 second. So while you're wrapping up, I'll put the link in the chat box.
Muy bien, gracias. Antes de darle la palabra al doctor Batistón para que te agradezca en nombre de todos los que estamos en el ITAES y que tenemos muchas ganas de verte personalmente en un futuro próximo, me pidió el doctor Guajardo Guzmán de la Fundación de Seguridad del Paciente de Chile que te traslade un saludo afectuoso.
Thank you.
Doctor Batistón, muchas gracias, Peter, y nos estaremos viendo pronto, doctor Batistón. Estás muteado, José.
Sí, agradecerle al doctor Lachman su excelente exposición, muy clara como siempre. Por supuesto, una lástima que este año no haya podido venir, pero bueno, nos veremos por ahí el año que viene en Florencia. También es un lugar muy lindo para encontrarnos. Y desde ya, desde toda la gente que compone el ITAES, de su equipo técnico, o sea, todo el ITAES, agradecerle la estrecha y siempre gran colaboración que recibimos por parte de la ISCUA. En un tema que ha venido, como se dice, para quedarse, y que día a día la gente interpreta las grandes mejoras que produce la calidad y seguridad en todo el ámbito de la salud. Así que, Peter, una vez más, muchas gracias, y también muchas gracias a todos los participantes, y espero que les haya sido de utilidad. Nuevamente, muchas gracias.
Thank you very much. It was a great pleasure to be here, and I put the article in the Zoom chat just in case you want to look at it.
Muchísimas gracias, Peter.
Thank you. Thanks very much. Goodbye, everyone.
Goodbye.
Bye bye.
Adios.